Hi, my name is Leah McKeskey. I'm a PGY1 at Baylor University Medical Center in Dallas, and I'm presenting a case of tuberculous meningitis in an immunocompetent young woman. So disseminated, which just means extrapulmonary tuberculosis, accounts for about 3% of cases in the United States. It's usually caused by reactivation of a latent infection and spreads to the liver, spleen, bone marrow, and brain most commonly. Risk factors include extremes of age, end-stage renal disease, diabetes, and immunosuppression. Those with a CD4 count less than 100 are at the greatest risk. So this case is a 26-year-old female who recently immigrated from Mexico with type 1 diabetes, who presented with just 1 week of cough, nausea, vomiting, and poor PO intake. She met sepsis criteria with tachycardia, tachypnea, suspected pulmonary source, and was started on CAP coverage. She got a chest x-ray and then a chest CT, which, as you can see on the right, showed innumerable small nodular opacities throughout the lungs. And the radiologist specifically said concerning for miliary TB. She also got an LP, which had an elevated opening pressure at 46, elevated protein, white blood cells, and low glucose. Meningitis panel was negative, but so was AFB. Right after this, she had TB studies come back positive, so her sputum culture, her quant gold, her BAL PCR were all positive, and she was started on RIPE and Decadron. Her headaches kept getting worse, though, as did her mental status. So repeat CT of her head showed an increased hydrocephalus. You can see this picture right here on the right. The one on the right is the initial CT, and then on the left is the repeat. Read as ventricular megaly and progressive moderate hydrocephalus. She was managed at first with serial LPs, which relieved her symptoms. She was discharged from the hospital, but then came right back with, again, headaches and altered mental status. She was actually taken emergently to the OR with neurosurgery, and they placed a VP shunt. She continued on RIPE and Decadron and slowly continued to improve after that. So, as far as risk factors go, this patient did have diabetes, but she was not immunocompromised otherwise, did not have HIV. Her symptoms also were only over this 1 week, just the cough and the kind of poor PO intake, no night sweats or other symptoms that we typically think of with tuberculosis. Definitive diagnosis of tuberculous meningitis specifically was hard, just because her CSF did not have Mycobacterium tuberculosis or AFB positive. But the sensitivity of these is not great, only 60 to 80%. And given that she did have proven TB and her CSF studies otherwise were consistent, the presumptive diagnosis could be made. Her neutrophilic instead of lymphocytic pleocytosis could be explained by just early stage TB. Hydrocephalus then, as the complication occurs pretty commonly, and the management is symptomatic control. Treatment of TB overall is, again, RIPE therapy and Decadron, continued for at least 6 months. So in conclusion, only 40 to 70% of individuals with disseminated TB are actually immunocompromised. So just the fact that someone is immunocompetent cannot exclude the diagnosis. Treatment of disseminated TB is just the same as pulmonary TB with RIPE, rifampin, isoniazid, ethambutol, and paroxetine. Treatment as well as Decadron, and hydrocephalus is a common complication, focuses on symptomatic control more than anything else. Thank you.
Yeah, no, that was
Non-stuff,
better.